Well, welcome to this Partnerships for Life webinar. It's really a pleasure to hear that so many, nearly 300 individuals have registered for this webinar. My name is Thomas Niederkrotenthaler, and I'm the coordinator for Partnerships for Life in the European region. And I'm really co-hosting this webinar together with Professor Murad from the Eastern Mediterranean region. So as you know, Partnerships for Life is ISP's signature program to promote the development, the revision, the implementation, and the evaluation of suicide prevention strategies and programs on a global level and within the WHO world regions. And there are a multitude of activities going on right now within Partnerships for Life. They are all listed on our website, so please check out our website if you are interested and if you are hearing for the first time about the program. However, many of you have probably had a lot of thinking about Partnerships for Life and involvement. Right now, many of you are involved in the situational analysis, which serves to get better insight into the structure and the state of suicide prevention strategies in each of our member countries. So we really appreciate your contribution to these important tasks. Another important area, obviously, are our webinars. They take place every 2 months, and each one of our webinars is co-hosted by 2 world regions. So today, this is a webinar hosted by the European region and by the Eastern Mediterranean region. And let me say a few things before we start. First thing is this webinar is recorded, so please be mindful of that. It's recorded and it will also be available for others to watch later on our ISP Partnerships for Life website. And then, of course, we want this webinar to be as interactive as possible. So we will have questions after each of the 2 talks, and I really ask you to put in your questions into the Q&A section. Please use the Q&A section, not the chat section. If possible, it's easier to have an oversight in the Q&A section. So please put in your questions, and I will then feed them to our first speaker, and it's a really pleasure to introduce him. Our first speaker, actually, there's no need to introduce him, but I still say it's a pleasure to say a few words about Professor Stephen Platt. Stephen Platt is Emeritus Professor of Health Policy Research at the University of Edinburgh. And he is an ex-vice president of the International Association for Suicide Prevention. And for the last few years, he has also been the global lead for the flagship program Partnerships for Life. So he has done really a lot of important work in this area for Partnerships for Life. And today it's really exciting that Stephen Platt is going to present on a study that we have worked on within Partnerships for Life. And Stephen will speak about the effects of national and regional suicide prevention strategies on suicidal behavior. It's a systematic review and meta-analysis. Stephen, please.
Thanks so much, Thomas. Many thanks for your very generous introduction. I will share the slides. There we go. Is that okay? Can you see okay? Great, thank you. So I'll push on because I know time is short. Here's the structure of the talk. So I'm going to say a little bit about the potential for national suicide prevention strategies. Say a word or two, but even less than I was intending now that Thomas has already made the introduction to Partnerships for Life. Talk about evidence on national strategies of effectiveness, report some preliminary findings from our systematic review and meta-analysis, and then talk a little bit about evaluation and how to make progress and make a plea that we all engage with complexity, but I'll come to that. So it's interesting, 1996, nearly 30 years ago, there was a meeting of the United Nations bringing together experts to talk about national strategies and the prevention of suicide. And what was interesting reading that report again, I was looking at it very recently, is that I was looking for a sort of statement about making the case for having a national strategy. And it turns out basically that it was already at that point a feeling that the case had been made, that it was sort of obvious. So you can see it in the title of it was the guidelines for the formulation and implementation of comprehensive national strategies. Feeling that this was work that was not so much in progress, but that should be done systematically and comprehensively across the world. The WHO has been promoting national strategies, so they strongly promoted evidence-informed strategies and had encouraged governments, in order to address the complexity and magnitude of suicidal behaviour, it should plan, implement and evaluate national strategies and action plans. And these strategies and action plans should, of course, be firmly grounded in research evidence. It's hard to give an exact total of countries which have national strategies. It's certainly now 40 plus. The majority of those are in upper middle and high income countries. The majority of countries lack such formal action, especially, but not confined to, lower middle income countries, where, of course, the majority of suicide deaths actually occur. The WHO is also a strong supporter of national strategies, and in the WHO's website, there's a reference to their recent Live Life package of effective evidence-based key interventions, and they call for the development and strengthening of a comprehensive national approach to strategies in a multi-sectoral public health approach. And YASP itself has now a policy position, which you can find online, the links given below, and recommendation that every country should adopt or make progress towards the adoption of national strategies and enhance and strengthen their strategic approach to suicide prevention. So the UN, the WHO, YASP itself, and many others are major supporters of national strategies and their promotion. So Partnerships for Life, Thomas has already told you a little bit about it. Its basic aim was to establish this international collaboration of experts around the world to support the development of national strategies, and with a broad long-term outcome of increasing the number of nations worldwide which have that commitment to planning, implementing and evaluating comprehensive strategic approaches to suicide prevention. And one of the objectives within this program is the promotion of learning about best practice and effective interventions to improve our approach to suicide prevention. In the course of doing the Partnerships for Life, there's a lot of work, and you go to the website. I was going to tell you more, but there isn't time about it today. But what's relevant here is the kind of knowledge building that we're trying to do, and then, of course, sharing. So Partnerships for Life have been involved in 2 systematic reviews, and I'm going to be talking to you about one of these, which is the umbrella, which is the review looking at the outcomes of national suicide prevention strategies. The other one is a systematic umbrella review of the effectiveness of individual elements or interventions within national strategies, and that too will be coming early next year. We've also got the development of the policy position I've mentioned, and just one other thing in terms of knowledge that you might not yet have had a chance to look at, but we have an updated list of national and subnational suicide prevention strategies worldwide, which builds on the pioneering work done in WHO and published in 2018, and it now updates on an annual basis these lists, and we've just updated the lists in both national and subnational. So do take a look to look at those. It's a fantastic resource of information with hyperlinks to the actual document, so you can see how different countries around the world have gone about the business of creating national strategies. So where are we? This systematic review and meta-analysis. The research team I should introduce: Camila Altavini in Brazil, Maggie Jameson, Heather McClelland in Scotland, Thomas Niederkrotenthaler in Austria, myself, Mark Signor in Toronto, and Mike Spittle in Melbourne, Australia. It's registered in the Prospero system, and we followed PRISMA guidelines. We've used the Robbins I tool for assessing risk of bias in non-randomized studies of interventions. And we searched 12 databases for relevant literature published in any language from inception to the end of last year. And then conducted additional searches. I mean, this is one area where it's interesting that only so much of the literature that we've actually found came through doing classic bibliographic database searching. Some of it came from looking at forward citation from colleagues, knowing about reports. Some of the publications are not they may be peer reviewed, but they're not in the form of an article in a journal. So it's quite difficult to find some of this literature, but we have managed to do that. And the search was limited to terms relating to suicide-related outcomes. So that's suicide, attempted suicide, or suicide attempt, and self-harm, whether or not specifically with suicidal intent, to words which cover the areas of strategy, plan, policy, or legislation. And we've been looking at, or we sought studies which would tell us something about comprehensive approaches to suicide prevention at both national and subnational levels. So subnational, for instance, the state level of a state in the United States. We actually have found 24 studies which are included in the narrative synthesis. The controls are typically historical data for these studies. So I'm talking about the quantitative analysis. They typically look at pre and post implementation in the same country. So how do the rates differ pre-post the introduction of a national strategy? Sometimes with comparator countries, in other words, countries which have not had a national strategy, and sometimes no controls. The most common research designs are uncontrolled, in other words, no controls before and after studies within the same country, and time series analysis, interrupted or other versions of time series analysis. The time frame of the studies varies greatly, so we've had anything up to 50 odd years before a strategy initiation and anything up to 13 years after strategy initiation. And the outcome in the vast majority of the studies are 22 studies of the 24 are suicide deaths. 2 studies looked at suicide attempts only, and 2 studies looked at both deaths and attempts. So that's how you get it looks like 26, but there are 24 studies in all. Little or no detail of the components of national strategies is provided. I'm going to come back to this, but it's really important in terms of one of the aims of Partnerships for Life, which is about learning and how much learning can be done in studies which actually tell you little or nothing about the strategies which are being implemented. I'm going to just quickly look at a few, I'm just moving that there. Right, I'm going to look at a few of the individual studies just to give you an idea of the kinds of studies that we've been looking at. This is from Schlicht-Thorsten et al. 2022. I should declare, I hope it's not a conflict of interest, but I'm one of the co-authors. So this is a study of looking at 24 countries with a national strategy over the period 2007 to 2019, undertaking interrupted time series models, testing for period effects, and adjusting in relation to underlying time trends. And we've looked at estimated period effects for total suicide rates. And as you can see, they range from significant declines in suicide post-implementation of strategies in countries such as South Korea, Chile, Lithuania, and Australia. In some countries, there are statistically significant increases in suicide, for instance, Uzbekistan, Sweden, also UK and Austria. But overall, the evidence from the 28 studies is of no significant difference across all those countries. So the pooled estimate of the period effect is in fact 1, and for the population, and for males and for females. It's the same result. But the interesting thing about this study is trying to show on a similar basis across all these countries that the variation in outcomes in relation to what happens after the introduction of a strategy. The Matsubayashi and Ueda study, which is now a bit old, but it's one of the first studies which looked at 21 high-income countries, OECD, 11 with the strategy and 10 without. The period there was 1980 to 2004, and there they were testing for statistically significant differences in incidence before and after implementation of the program. Interestingly, it was one of the few studies to actually look at comprehensive controls for other factors which might influence the outcome of suicide in addition to any strategy. So they controlled a number of variables which looked at the different characteristics of the countries that were in the analysis, including political, economic, and socio-demographic characteristics. And they found that overall suicide rates decreased after implementation of national strategies. The reduction was about 1.4 per 100,000, which was equivalent to around 5%. The impact was more pronounced amongst men compared to women. It was found significantly among youth under 25 years and older adults 65 plus years, but there was no significant impact of people of working age, so the 25 to 64 age group. Sorry, Lewicka et al. 2019, are National Suicide Prevention Programs effective? And they compared 4 what they call VERUM countries, countries with a strategy, Finland, Norway, Sweden, and Australia, and 4 control countries, which were, the controls are very carefully selected on the basis of some equivalence in relation to culture and religion, historical and political factors, socioeconomic, population size, and published statistics quality. They undertook a segmented regression analysis of interrupted time series data and found a significant decline in suicide among males and females in country with a national strategy after 2 years. The decrease in suicide rates in countries without a national strategy was not statistically significant. And I just show here that I've just copied the graphs from, that's all males in countries with suicide prevention strategy, and below all males in the control countries, looking at changes in rates over time and looking at the trend line. But what's interesting about this study is that they then did quite correctly, they looked at the difference in difference. In other words, was there any difference between the countries in the trend over time? And their conclusion is, after analysing the differences in suicide rates between VERUM, in other words, countries with strategies, and control countries, no significant level changes or trend changes for all demographic groups appeared. So for overall males, females, or age groups. And then went on to say, overall, this study demonstrates that national suicide prevention programs are effective. Well, it depends how you look at it. If you take the first graph and look at the change over time, it looks that it is. And and you can point to the fact that the trend for countries with a strategy is statistically significant, and for those in the control countries isn't. Nevertheless, when you look at the difference in the difference, there is no significant difference there. So my personal view is that this sort of overstates the case, but it does raise interesting issues about how you draw conclusions from this kind of statistical analysis. And the final one to point out to is an interesting one. It's in a preprint database, Research Square, and it's the impact of legislation on Suicide Prevention Act in the Republic of Korea, South Korea, an interrupted time series. And you'll see that I've just picked out 2 graphs out of interest. In Korea, the Act, just to say, the Act on the Prevention of Suicide, so the Suicide Prevention Act, It was enacted on the 30th of March 2011 and enforced the next year. Okay, so it's unclear what enforced means here, but I take that to mean implemented, and that the year 2011 to 2012 was a sort of preparation year following the publication and agreement of the legislation. So they then looked at different groups and found significant changes, improvements and reductions in suicide prevention in all age groups over the age of 30 years. And I've just picked up two slides here, which look at 70 to 79-year-olds and 80-plus-year-olds. And you'll see that the decline here, the sharply upward trend from 1980s right through to 2010, around 2010, and then a decline. But note two things. One is that the decline in the 70 to 79-year-olds actually starts in 2011, which is the year that the legislation was enacted but not enforced. And if you look at on the right-hand side, the suicide rate over 80 years, you can see that for 3 years prior to 2011, in fact, for 4 years prior to the enactment, you've already got a downward trend. So it's, if you did a join point analysis there, you'd probably find that the key year when everything changed is actually 3 or 4 years earlier. It predates so I'm just, again, it's about the sophistication that's needed in order to be able to make very clear-cut conclusions, to reach very clear-cut conclusions about these studies. It's quite difficult, and one needs to look at these graphs very carefully indeed in order not to draw the wrong conclusions. So the lack of past efforts. The final bit is Anthony Jorm's piece in the Australian New Zealand Journal of Psychiatry, where he shows the timeline of various different kinds of interventions that have occurred in relation to mental health and suicide prevention. And he takes a crude, I think it's a crude suicide rate in the whole population over time. And it comes to the conclusion that there's a lack of impact to prevent suicide. So can somebody please explain it? And the quote is, even though the interventions of the figure may not be exhaustive, the striking impression is that past efforts appear to have made no discernible difference. So let's leave aside whether we agree with the interpretation or not. There's obviously quite a lot of different ways that one might look at the data that are available. And it's far more than we thought was available in order to try and reach some conclusions about suicide prevention strategies. And there's clearly a lot of evidence of good things happening, but also the evidence is mixed. So we undertook a better analysis. We've computed a range of estimates comparing rates before and after introduction of national strategies. We made a decision a priori that we would only pool estimates when there were at least 3 studies available. And in the end, having looked at all these different studies and the data available, we came to the conclusion that the only data available were for pre-post rate ratios. In other words, comparing rates pre-implementation of a strategy to rates post-implementation. And we therefore undertook a multi-level meta-analysis to pool the rate ratios. And the value of the multi-level analysis is it relaxes the assumption that estimates are independent. And that's important because, as you've seen already, we've had multiple estimates from a single study. So we estimated the rate ratio for each country and the pooled ratio overall. Sorry. This is the first of the kind of our early results, and there's more work to be done, showing the estimates for 5 separate studies. 2 of which have 1 country, DeLeo and et al. Have 4 countries, the Page study 2 and the Schlicht-Sourced, which I've told you about, 24. Overall, there was a slight reduction, 0.96, which just includes 1, so not statistically significant. But all 94% of the distribution of relative risks are all, risk ratios are all less than 1. As you can see from the graph on the right, meaning an overall preponderance for there to be a reduction in suicide following the implementation of a national suicide prevention strategy. So there's only 5 studies in there. We may be able to expand that. But a lot of the studies, they just weren't amenable to the kind of meta-analysis that we wanted to do. So just a quick, have I got a couple of minutes just to, Thomas, to just to say a little bit about what I think we need to do now? Is that okay? So I talked about complexity. I mentioned complexity earlier, and we need to think of suicide prevention strategy as a complex intervention. And we need to understand what the implications of this are for both implementation and evaluation. We have to focus on assessing and understanding the process, so implementation. We need to understand the intermediate outcomes and the impact and the relationships between these. And above all, we need to open the black box of implementation. It's long overdue, through a more appropriate and realistic evaluation methodology. I don't think personally it'll be possible to attribute specific outcomes to a specific strategy as a whole or either constituent elements, but we may be able to reach some conclusion about its contribution to intermediate outcomes and impact. So by complex intervention, I'm talking about it comprises multiple interacting components, and it arises from both the properties of what the intervention is, the context in which the intervention is delivered, and the interaction between the properties of the intervention and the context. Interventions become more complex in line with increasing the number of components, the range of behaviours, expertise and skills, the number of groups and organisational levels and settings that are targeted, and the level of flexibility or tailoring of an intervention that's permitted. So how dynamic or adaptive is the intervention? We need to think about context as well. So by that, we mean any feature of the circumstances in which an intervention is conceived, developed, implemented, and evaluated. And of course, context is dynamic and it's multidimensional. And whether and how an intervention actually generates an outcome is hugely dependent on the wide range of contextual factors. And these factors will be specific to the intervention and they may be difficult to anticipate. So context interacts with, it influences, it modifies, it facilitates, and it constrains intervention. And here you can see the influences, what I call the suicidogenic context, which is the various influences on suicidal behaviour that we might think of as forming part of the context, the physical aspects, cultural, including religion, social, the economic, the political, the historical trends within a country, and elements of infrastructure. All of these are really important in understanding context. And without taking that into account, we can't really make, I think, reach a sophisticated understanding of what difference a national strategy has made to suicide incidents. So we need to capture what's happened, what to do in the future. We need to capture what's happened nationally and locally. We need to understand the contribution of the architecture and components of the strategy. We need to identify the most active components and look out for components that may have no or negative contributions. We need to understand how the context has affected implementation and outcomes, so we have the correct interpretation of our findings, and we need to provide direction for future suicide prevention strategy and action. I think you'll probably agree with me that the kind of research that's been done thus far does not really begin to capture what we need to do in order to draw out any really useful learning from evaluation. Because at the moment, I think that we're far from that. We need to do more. And just my final thing, really, in two words, for summarising the talk, is really embrace complexity. Thank you.
Thank you so much, Stephen, for this great oversight on this research. And I apologize, there's some urgent construction work going going on just next to me, so please let me know if you can't hear me. I see there are no questions right now in the Q&A section, so please put in your Q&As, but just one question briefly. You made a strong call, Stephen, to consider complexity, to make evaluations more appropriate and more realistic. Now, we've had a lot of discussion in Partnerships for Life also about the social determinants of mental health and suicide, and how they are actually the most powerful agents potentially driving suicide rates across the globe. And how do you see are those determinants currently reflected in that research?
Well, there is actually, there's been no attempt thus far to pull together what evidence we have about social determinants and suicide. And I've been part of a group that's actually produced such a systematic review, and it's currently under review, and I'm hoping that it will be published. So there is a literature out there. There's a much bigger literature in relation to mental health. So this is more specifically about suicide, and a lot of that, of course, is around the economic sphere and suicide. Mm-hmm. So there's a I should think of all the literature pulled together for that review, that the number of studies around the economy, particularly economic recession, sudden rises in unemployment, to try and understand the impact on suicide. I mean, which is a mainstay of social approaches and sociology of suicide, isn't it? I mean, we've been looking at that for years. So I hope that systematic review will be published and will be a useful addition. But there are many other, I think, ways in which understanding the more universal aspects of suicide is really important, that we continue to look at these universal influences and think about the universal approaches to prevention alongside those that are very effective and important in relation to high-risk groups, so the selective and indicated approaches. But I still have to say, I don't think we know enough yet about how to get the balance right. I think it's quite easy to say now we need a mixture of universal, selective, and indicated. But I'm often asked questions by civil servants as to say, well, okay, I accept that. So now can you explain to me what kind of mix we need, that we should be putting money into, of different kinds of approaches at different levels? What will be the best bang for the buck, if I can put it that way? What will deliver the best in terms of reducing suicide? And I don't think we're in a position to be able to answer that question. Mm-hmm. Yeah. Mm-hmm.
Thanks so much, Stephen. Thanks for sharing this important insight. And also, we are looking forward to hearing about your other systematic reviews, maybe in one of the next webinars in 2025. And I ask everyone to put in your questions in the Q&A section. Now, I'm handing over to my co-chair, Professor Murad Khan, who will introduce our second speaker.
Thank you very much, Thomas, and thank you, Steve, for that excellent presentation. Second speaker is Professor Yousef Khader from Jordan. Now, we don't hear too much about or from countries like Jordan, which is in the Eastern Mediterranean region. So I'm very pleased that Dr. Khader is presenting today. Professor Khader is Professor of Epidemiology and Biostatistics at the Jordan University of Science and Technology. He's also the director of the Center of Excellence for Applied Epidemiology at the Eastern Mediterranean Public Health Network. Professor Khader has degrees in public health, a master's from Tulane University, as well as in epidemiology from the Jordan University of Science and Technology, and a master's in medical education from Maastricht University, and a PhD in epidemiology and biostatistics from Tulane University in the US. We don't really have much information on suicidal behavior from countries like Jordan. When I approached Professor Khader, he said he did not have too much data on suicide, but he certainly has data on mental health issues, particularly trauma in children. And so he's going to talk about mental health status among children and adolescents in Jordan. And I think we probably will hear about some of the risk factors that may be contributing to suicidal behavior in Jordan. So I'll hand over to you, Professor Khader. The floor is yours.
Dr. Murad, do you hear me?
Yes, we can hear you.
And you see my slides?
Yes, you can
Thank you
see
so
that.
much. Thank you so much. Good morning, good afternoon, and good evening, everyone. Thank you so much, Professor Murad, for inviting me to present. You are definitely right. We lack Jordan, as well as many countries in our region, lack accurate data about suicide behaviors. So today I'd like, but does not mean that it is not a problem. It's not a public health problem in the region. We are, seeing some statistics that really are alarming in Jordan, but because of lack of data, difficulty in sharing data, make to report an evidence challenging. So today I'd like, to present the findings of our recent survey. It's a national study for mental health status among children and adolescents in Jordan. This project is implemented in collaboration with multiple organizations, and it's supported and funded generously by JICE. You know that I'm sure that you are aware where's Jordan. Jordan is a country in the Middle East with a total of population 11 million. Jordan hosts a significant number of refugees. Almost we host 1.3 million Syrian refugees and host almost 2.4 million Palestinian refugees. The Jordan population as well as refugees population are young populations, where almost 44% of Jordanians and 54% of refugees are either children or adolescents. Before we start our study, actually, there are multiple organizations providing, mental health interventions in the country, but still we lack really accurate data about how spread are mental health and psychosocial problems, specifically among children and adolescents. So before we proceed to a national survey to provide the best estimate, we conducted a scoping review that is published in the Journal of Children. And we included in this scoping review a total of 28 studies. And as you clearly see, that there was a wide variability in the prevalence rate and estimates of various mental health problems. It's funny to see that the studies are reporting prevalence among children ranging from 7 to 74%. For example, anxiety, it's range from 16 to 46%. So we could not rely on the previous findings, especially almost all countries are not representing the populations, and they also suffer from methodological errors. So the decision was to move to conduct a national survey to have a better picture. So we conducted this study to generate a robust evidence regarding child and adolescent mental health situation in Jordan to facilitate national policy making process in Jordan. Basically, we examined the prevalence rates of symptoms of common mental disorders specific to children and adolescents. We conducted a large scale national school-based cross-sectional study again, among children and adolescents, we included children from grades 3 to 12, and for those who are attending all type of schools, including public, private schools, and also ANARWA schools. ANARWA schools basically provide educational services to Palestinian refugees. And also we included data from children living in Za'atari camp, which is one of the biggest camps. And also we included samples from non-formal education centers. But for those, the data is not included in this study. Overall, we included 8,000 children and adolescents. We used two different surveys or survey sets to collect the data. One is a self-report version for students in grades 7 to 12. And we use a proxy parent version for parents of students for those in grades 3 to 6. We use various study instruments. They are used in commonly used in research. They are not diagnostic tools. They are most probably screening for symptoms of different conditions. Revised children's anxiety and depression scale is a long version, but it is well-known version. Strength and difficulty questionnaire for assessing behavioral and emotional problems is used in our study, plus other tools like adverse child experience. We also assessed the quality of life, general help seeking questionnaire. We looked at dietary habits, physical activity, sleep disorders or problems, problematic internet user questionnaire, plus others. Also, we looked at smoking because we requested to have data about smoking. So as you see here, we have almost 62% of our sample are Jordanian, 20% are Syrian refugees who are living outside the camp, and 13% are Syrian refugees who are living, children or and adolescents living inside the camp. And also we have 2% of Palestinian or children and adolescents living in Palestinian camps. We have one group children we stratified by age group, children from 8 to 11 years. So they filled the parents' proxy questionnaire. And also we have adolescents of aging from 12 to 18 years. Now I'd like to look at, the prevalence rates of various conditions. All estimates are really alarming in Jordan. Now look at anxiety and depression. 17% of children had major depressive disorder, higher proportion among adolescents, 22%. For anxiety, almost 1/4 of children and adolescents had total anxiety. The most common anxiety symptom or disorder is obsessive compulsive disorder, affecting 40% of adolescents and 1/3 of children. And also other disorders are common, like separation and anxiety disorder. Panic disorder is prevalent among adolescents. So now I'd like you to look at the rates of depression disorder and anxiety according to nationality. It's clearly, now look at orange one, you see almost 1/3 of Syrian refugees, regardless they are living in the camps or outside the camp, have total anxiety. And also the rates of major depressive disorder, almost 1/4 of children. Now, I'm sorry, now this slide is for children. The next slide is for adolescents. So as you see here, that almost 1/3 of Syrian refugees had total anxiety, and 1/4 of children have major depressive disorder. So these rates are much higher or at least higher than those among Jordanians and Palestinian camp refugees who were living in the country since long time ago, years, decades actually. Now look at the symptom now, anxiety and depression symptoms among adolescents. You see there is little variation between the percentages. You know, it seems that adolescence is a critical period. It has its own stressors. So when we look at adolescence, we don't see big variations in the estimates according to nationalities. Please ignore other. It's include other, but it's I suppose not to appear in this study. Now, when we use the strength and difficulty questionnaire to look at emotional and behavioral problems, as you see, total difficulty here is a factor of peer problems, hyperactivity, conductive problems, and emotional symptoms. All domains, but not prosocial behavior. So we see that these emotional and behavioral problems are also prevalent among adolescents. Almost 1/5 of them has such problems, and almost 14% of children. So we looked at main adverse childhood experience. So the study was conducted in 2023, still a recent study, and the data now is well utilized actually to develop interventions, plans, and policies. Excuse me. For children age 8 to 11, you know, women or mothers or parents said that my child or family member have been infected with COVID-19. Still, COVID-19 is really a stressor or a factor that affect the mental health. So these are adverse childhood experiences. Another one following the COVID-19 is reporting that they don't have enough children, they don't have enough to eat or to wear all the clothes. So we use a scale actually, and some of the items are revised to fit, you know, the situation in Jordan. Failing an exam, also it is an adverse childhood among children. So we have almost a list of 15 adverse child. These are the top ones for children. Now for adolescents, again, we see that also COVID-19 is still a factor. So infected or a family member infected with COVID-19, it was reported as 60% that has impact on their mental health. Failing an exam, and also another factor, adverse event, sudden accidental death of any of the family members for any cause. So we looked at, you know, post-traumatic stress disorder symptoms, and you see that according to the scale we use, 1/4 of children and 1/3 of adolescents have PTSD symptoms. Now, look at the variations of the rates according to nationalities. The blue one is for adolescents. Now, orange is for children now. So you see they are really among, look at now adolescent, 36, 36, 34. So normal, you know, not that big differences according to nationality. Almost the same thing actually. I don't see that 20 is too far from 30 when we report the rates, but you know, the rates are close, 30%, 27, 20%, close to 20%. So there is, so what I want to say is post-traumatic stress disorder symptoms are prevalent among not only Syrian refugees because of the traumas they face and the experiencing, the environmental factors or the living condition they experience. It's also common among Jordanians. Look at health-related quality of life. Their health-related was rated poor at different domains, especially among adolescents, the orange one, among adolescents for 2 domains of equality of life: physical functioning and emotional functioning. Also children actually, so they have poor related equality of life related to physical functioning. Quality of life stratified by nationality for children and adolescents. All nationalities are affected by the poor quality of life, and the complaints of poor quality is more evident among adolescents. We ask about intention. We wanted to assess the intention to seek help and sources for help. For parents, only 28% intend to seek help for their children in the event of they experiencing a personal or emotional problem. Only 28%, almost 1/4 of them. But the good thing that they will seek help from the right, source, right people, mental health professionals, practitioner or specialized doctor, and school counselor. For adolescents, the picture is different. 20% only reported they will seek help if they have a problem, emotional problem. But adolescents tend to seek help from informal sources when they feel that they have a psychological problem. They would seek help first from their parents or one of them, a friend or relative. Smaller percentage of them will visit a specialist or a practitioner or mental health professional, most probably because of stigma. Sleep problems, sleep disorders, also prevalent. Look at adolescents. More than half of them related to awaking during night and excessive day sleepiness. 52%, 58%. Also children, 1/3 of them reported excessive daytime sleepiness, reported by their parents, basically. Internet use, problematic internet use, I see maybe, in Jordan, children and adolescents are really addicted to the use of smartphones. 35% have problematic internet use according to the questionnaire or the tool or the scale that we use, and almost half of adolescents have such a problem. We had requested, to report data about smoking from Ministry of Education. We are requested by multiple organizations to have data about, drug use, but we did not get an approval to estimate or to study drug addiction. Very prevalent. Jordan ranked #1 in the region. I'm talking about adults in the prevalence of smoking, and rank #5, top 5 country worldwide. The problem is not only for adults, also for among children and adolescents. Almost 1/5 of adolescents reported smoking water by. 15% are using electronic cigarettes, and 10% are smoking cigarettes. It's common, actually. The problem is for both, for males and females. When we come to adults, actually, we see that the prevalence is much higher for males compared to females. But for children and adolescents, the rates are almost, close together. Based on the findings of this study, we reach, multiple recommendations. The good thing that is now the recommendations are implemented now. We recommended adopting integrated and coordinated plans and programs to intervene in several levels, including policies, community schools and health services, especially primary care, family level, and children and adolescents themselves. We have recommendation for schools and teaching staff, and we recommend, based on the findings, to expand existing efforts to strengthen teachers' capacities in providing psychosocial support. or at least to be able to recognize such symptoms and refer them to receive services. We also have some recommendations about, working on the teacher training curricula that include themes related to dealing with parents and society. Clear channels of communication between the counselor and the primary healthcare providers. Usually, counselors in our schools, they don't provide psychosocial support. They have to, but basically they involve them in teaching, like, teaching arts or teaching sports, something like this. We also recommending actually enhancing the role of teacher and counseling in the early of detection of symptoms of mental health. And to provide a better evidence, actually, we conducted a separate study in the included schools to look at the provision of psychosocial support to students in Jordan. We looked at their knowledge, attitude, skills, practices, and perceived barriers. And now for school, the findings are now of this study is utilized to develop intervention at a school-based. Specialized services, there is a need to prepare a map for mental health services and disseminate this information to teachers to provide them with the necessary knowledge and tool that facilitate the referral process, especially the complex cases. And also we recommended to integrate actually mental health and psycho support in the primary care level. So there is a need to train primary health care providers because, providing mental health services is not within the package, the benefit package in a primary care. At community level is also a need for awareness campaigns, parental support programs, these are also needed. Also at policies level, we have some recommendations. And at the end, recently, we succeeded to publish the findings of this study, overall findings, psychosocial, emotional, and behavioral problems, quality of life, and mental health care seeking behaviors among children and adolescents in Jordan. It's published in Frontiers in Public Health. Thank you so much.
Thank you so much, Professor Khader. That was very interesting to hear about prevalence of mental and emotional health problems in a country, like I said, we don't hear too much about. I don't see any question in the question and answer section.
Well,
But
Murad, there are two questions. Should I just read them?
Is it for Professor Khader?
It's for Professor Khader, yes.
Yeah, go on, please. I must have missed it.
There's a question. Sri Lanka does not have a national policy for suicide prevention. What steps do we need to implement it?
That's probably for Steve.
I guess for Professor Steve, yeah.
Sure. I mean, well, you can't implement you can't implement a policy or strategy if there isn't one. But more helpfully, I can say that I think we've realized in Partnerships for Life the huge range of starting points across countries. We get dazzled by the fact that there are countries at one end of the scale, such as the United States, which are currently in their third version, I think, or is it fourth version of their national strategy. Even a country as small as Scotland, with we are in our second. Ireland's about to start as we're finishing its second, and is about to look at a possibility of a third strategy, and so on. So that's at one end of the scale. At the other end of the scale, you have countries which either have virtually no activity at all, and where suicide may be criminalized. And the challenges are at that end of the scale, really, aren't there? So it's for many countries, and that's why we've when we talk about adopting a strategy, we also talk about making moves towards the adoption of a strategy. In other words, how can one begin if there is really very little there on the ground? And what we say is two things, really. Is one is go Partnerships for Life should be supporting countries in the interventions which already exist, however small. And typically that might be a crisis helpline for a limited number of hours a day. And that's all that's being done. It's probably run by an NGO with very little money, difficult funding, and so on. And our advice would be that's where you start. You start trying to provide to support the country, to extend the hours, to provide more help, to then draw in others who are working in or have the potential to work in suicide prevention, and try and create a team around the existing structures that are there. If there's nothing there at all, as there isn't in many countries, then our job has been and continues to be in Partnerships for Life, try and find people who are interested and maybe are looking to do some work in the field, or maybe have done it in a very informal way, but where there are no clear structures and there's no finance yet, and to support the people that we can make contact with to actually get something off the ground, the first program of some kind. So it's, you know, don't be put off by the ultimate aim. And I think it's, although the evidence, as I've shown you, is very mixed, but the evidence isn't telling us it's not worth doing it. I don't believe. That's not my reading of it. The evidence is saying that there are some situations where national strategies are valuable, and that we should be working towards supporting countries to reach that end. But in some countries, that might be years away. And we should be doing all that we can to help countries, whatever the level of action that's already being taken, and to support them to grow that action.
Any other questions in the Q&A section, Thomas?
Yeah, there's one more. They say it's an extra question, but please reply. The question is, what's the main role of epidemiology in public health? So it's not directly related. Is any one of you wanting to address this? Yeah, Professor Khader?
Yeah, thank you. Yeah, honestly, this is really brilliant question to ask, actually, you know, because when we look at the public health programs in our region, basically they are really looking at academic programs in public health. They are not focusing on public health practice, you know. So our programs is training the majority, actually. I'm studying this, by the way, and I'm involved in developing a comprehensive framework for public health professionals. The role of epidemiologists is really very important and essential. Now, the whole world now is calling for integration of public health functions at health systems, and also now the competence. So I advise you actually to read about competency framework for epidemiologists to see how is amazing the role of epidemiologists in providing public health services.
No more questions on the Q&A.
So if I can just pose one question to Professor Khader. You know, the slides that you showed had 4 groups. One was Palestinian, then Syrian, urban and in camps, and then Jordanian. I was struck by the fact that the Jordanian children also had relatively high prevalence of mental health disorders. One can understand in the Palestinian and the Syrian children being displaced and living in different kinds of settings, not having a structured and a stable life. But can you tell us a little bit about the child rearing practices in Jordan? Why are the rates of mental health disorders so high in the Jordanian children in the survey that you did?
Yeah, thank you so much. You know, this is really good questions. And in an earlier study, actually, we looked at, nationality-specific stressors. While we found that, for example, the war-related stressors, the living status-related stressors are, common among Syrian refugees. We found that there is unique stressor among Jordanian children, one of the most, ranked stressor is family disintegration, honestly. Uh, I guess and I feel and I witness there is some problems in raising children in practices in the country. So family disintegration, and we started to see high rate of divorce nowadays. Things are changing honestly in the country. Plus the socioeconomic status, still the Jordanians have really not that good socioeconomic status. Almost 30% of them have low income, high rate of unemployment. All of these actually are affecting. So I would relate this to socioeconomic status. Some families actually claim that even, children are in the camps are receiving better care, better health services, better education services because of the big funds that are, coming to the camps, refugees, leaving children behind. So the answer to your question is uh, the poor socioeconomic status that create conflicts in the family and result in family disintegration.
Thank you.
Thank you. There are no more questions, and we are a
There
little
is,
bit.
there is, Thomas.
Oh, okay.
What do you think about the urgency of establishing self-harm surveillance systems, considering that self-harm is the strongest predictor for suicide? Or is it more essential to establish suicide registers? What is a good point to start establishing such surveillance systems? Maybe I could answer that because I've been working in this area. It's a really good question. It really complements what Steve said earlier about countries that don't have any national suicide prevention strategy to start with something what may be there and then work on that, like a telephone helpline. So setting up a surveillance system for self-harm is also one of the things that one can invest in. Most of the self-harm cases, not all of them, but most of self-harm cases end up in health facilities. And setting up a surveillance system whereby you routinely collect data on self-harm cases um, will really provide you with very important information over a period of time. The minimal variables that you should record are age, gender, and marital status. But of course, if you look at some of the other reports from the WHO, it's something like 20 or 30 variables that you can get information on. So it depends what are the facilities and can the data be collected routinely or not. Similarly, so that is much easier. It's a low-hanging fruit which you can set up in a health facility. And then once you have it in, say, one health facility, you can expand it to others. The suicide register is much more difficult to establish because how is suicide certified in your country? Who makes the determination? Who gives the certificate of death, and whether manner of death is written on that or not? In most countries outside the Western world, it is the police who get involved, and it is the police who make the determination of suicide, that this is a suicide. But if you can access that information, that's very good. But you cannot set up a register of suicide without involving the police in other countries, medical legal authorities in other countries, maybe the Ministry of Health. So study what is there in your country, how it is being done, and then try and study that. And then through that, you can do some training workshops to improve the processes of certification of suicide. But anyone really trying to study suicide and self-harm, I would suggest that try and establish a surveillance system of routine data collection for self-harm cases that are brought to a health facility. And majority of them, again, depending on the setting, would be the cities or the towns government health facility where you will get most cases. There's a editorial in Crisis a couple of months ago that I co-authored with a colleague, Dr. Raki Dandona, which really talks about administrative data and how you can interact with the different different agencies in your country to get good data. So, try and read that. Thanks very much.
Wonderful. And now there are actually the questions coming in. So we have 3 more questions. Let's see. So here it says India depends on agriculture. There are many suicide cases due to many farming and land problems. As a community health nurse, how can we eradicate the suicidal tendencies of farmers?
So if you don't mind, I can do that. So India does have a problem with farmer suicides, and it really goes back to the time where the policies changed on the seeds and GM seeds were introduced. But they've also been really good study. My colleague, Dr. Lakshmi Vijay Kumar, has done some wonderful study about the accessibility to pesticides in villages, how you can store them in a safe manner. And there's a study in Sri Lanka of locked box storage by Professor Keith Horton and colleagues. So you can look at these studies, but I think one of the most important things is about education and raising awareness. So yes, you try and control the method of the suicide, and in farmers it's really pesticides, how you can store them safely so that they're not easily accessible at the time of a suicidal crisis, but it's also raising awareness is very important. Primary prevention, and then if someone does make an attempt, does survive, then what can you do for secondary prevention through good psychological and psychiatric intervention? So those are kind of the things you can do. And nurses education, nurses being able to identify cases at risk, nurses being able to have basic skills of counseling, and then signposting if the person is suffering to psychologists or whatever mental services are there can be a way to deal with this. Thank you.
Can I add to that, Murad?
Sure.
I was thinking the question about this use of the term suicidal tendency, and I think that makes it that maybe over psychologizes. It depends what we mean by tendency, but the point that you raised is really crucial. You can have populations with the same level of suicidality, however it's measured, but if the culture is such that people would in one culture might reach to the kind of medications that they have in their cupboard in their bathroom, the analgesics or common drugs on the one hand, or in a country where people reach for guns because they're very common, or a country where you reach for pesticides with an unbelievably high level of toxicity, you could end up with 3 populations of people, all with the same level of suicidality, but with completely different suicide rates, because you're dealing with the harm associated with a method. And sometimes that doesn't tell you anything about the underlying suicidality. All it tells you about is what prevails in the culture in terms of the methods that people use. So I think the point I would make, in addition to what you're saying, to add to Murad, is the need to understand this from a more cultural or societal perspective, as well as understanding it at the level of the individual, is really important.
Yeah.
There are 2 short questions. One is for Yousef Khader. Can you comment on whether this sample was representative of the actual population?
Yeah, thank you so much. Actually, the rationale of this study, or the idea behind the study, is to select a representative sample, because the previous studies were suffering from lack of external validity. Definitely, we use a representative sample. We utilize, stratified multi-stage cluster sampling technique, actually, to select a sample that is also proportional to the size. Also, our analysis also that is proportional to the size. Also, we reported weighted estimates. Plus, we conducted I simply reported overall summary statistics, but in other publications that we are working on, we conducted multi-level analysis. So because of the clustering of individual within classes and within universities. So the definite answer is we claim that we utilize a good sampling approach to achieve representativeness.
Mhm. That's great, thank you. And then the final questions, are there opportunities to do similar research in the refugee settlements here in Uganda? If yes, how can I get involved? So I think that's for our contact person in Uganda. So maybe if you can drop an email to Stephen Platt, who's the global coordinator, and he will get you the contact person. Or Stephen, you probably don't have those names with you. So please drop an email to Stephen Platt, and we can get you the contact person for Uganda, and you can approach them and see what the opportunities are. Are there any other responses?
Yeah.
Mm.
Yeah, actually, I'm aware of for literature in Uganda. We worked in Uganda in some projects, you know. So there are really multiple studies on refugees in Uganda about, you know, their psychosocial and mental health problems, not only children, also adults. So, but it's good actually to be involved in such type of research. Now we, you know, see that Africa CDC now is investing or huge efforts now to you know, to conduct research in mental health and also to build the capacity actually of health professionals in various countries in Africa CDC. EMPHNET also in Africa has also some programs related to mental health.
Wonderful. Great. So thanks. This concludes our Q&A section, and this concludes our webinar series for this year, for 2024, and we will definitely continue in 2025. There's also the first preliminary date, which is on 11th of February. So stay with us for a confirmation of the dates for 2025. Thank you again to our wonderful speakers, Professor Khader and Professor Platt, and thanks to you all for your questions, and see you latest next year. Goodbye.
Goodbye.
Thank you. Bye-bye.
Bye-bye.